Hey, Rick Bukata here. Normally these lectures are done at a live course, but unfortunately this lecture was not able to be captured at one of the 2008 Emergency Medical Abstracts courses. So we've elected to do this in front of our camera here in the studio. It's going to leave a little bit in terms of interaction between us, but in any case, this is how we had to do it. This chapter, as you probably know, was written by Jerry Hoffman, and Jerry did a nice job. I'm going to go picking and choosing some of the parts I'm particularly interested in, if I could. You know, one of the things about reviewing the medical literature that appears to be a little tough is some people think I need to know about statistics and likelihood ratios and p-values and confidence intervals and hazard ratios. And, you know, I'm sure that that's probably true for people who really want to get into the literature. But I think for the majority of us, there's lots of things that are easily done that will help us take a study and say, can I use this study in my practice? And that doesn't require any kind of knowledge of any kind of statistics, but it's more actually fundamental. So I think in the study, if you look at a study, you ask a couple of things. One of them, is this conclusion valid? And that's the part where you have to kind of have some sense of the mechanics of the study. You have to read the methods, ascertain whether the results seem valid. You may not understand some of the terminology and the two-tailed t-test and all that other stuff, and certainly I don't get that either. So first of all, the results seem valid. And then if they do, can you extrapolate those results to your population, your patients? And that is a much easier thing to determine, and we'll go through some of the elements where you look at that in a bit. One of the things that Jerry talked about is really important. It's called distinguishing between causality and association. Many studies are really focusing on associations and not causality. As an example, he makes the point that beer drinkers have more lung cancer. There's an association between beer drinking and getting lung cancer. Does beer drinking cause lung cancer? No, beer drinking doesn't cause lung cancer. It just so happens that there's this association. What is the real relationship? Well, actually, beer drinkers smoke more, and smoking causes lung cancer. So there is an association, but no causality. Good example, I think, there. They talk about the randomized controlled double-blind trial as kind of the gold standard to determine this is the cause of that. And we can understand that, but we always can't do those kind of trials that are expensive, and many of them even don't hit the mark, and I'll show you some examples. One of the things that's important in at least some studies is the use of placebo. Why is that important? Because there's a lot of good examples. One of them is the studies that look at the use of antibiotics in the treatment of otitis media. Those studies, I can tell you, and also sinusitis and bronchitis as a generic class. All of those itises have real problems. One of them being that there's often no gold standard for the diagnosis, being one. But in any case, so if you have a disease like otitis media, where the diagnosis is often incorrect, and when the diagnosis is correct, the diagnosis may be due to a viral illness rather than bacterial illness, it's very difficult to show that the world's strongest antibiotic is any more beneficial than the world's weakest antibiotic in the treatment of otitis media. In these studies, lack of gold standard and viral causation basically makes it virtually impossible to show that one antibiotic is different than another. And yet, almost all the studies that look at antibiotic A versus antibiotic B in otitis, bronchitis, and sinusitis are manufacturer-supported trials that don't include placebo. Why would you include placebo in those trials? Because you will find something that you really don't want to find, that A is similar to B is similar to placebo. And when you find those three things, it's like, what? And in those conditions, when manufacturers support those trials, they say, okay, well, since the results are pretty much the same, our drug is the better drug to choose because you only have to take it once a day. You only have to take it for 3 days. The fact of the matter is that you may not need to take it at all. They may say, well, compliance is better with this antibiotic. Well, that may be, but the fact is compliance with antibiotics in otitis, bronchitis, and sinusitis may be irrelevant. So no drug company in its right mind, would fund a study that would include their antibiotic, another antibiotic, and placebo in those settings. Occasionally, rarely, you see those studies, and the results are extraordinarily predictable. A versus B is always the same, and sometimes they, by mistake, they throw in a placebo. Oh, holy smokes, they're all the same in these cases. So placebo is important in a lot of trials. A little crap, I'm getting 2 new voicemails. I'm not going to listen now. Little chop. Another thing I think that is important to consider is what's called external validity. So this trial basically showed that in this subset of people who have strokes, that TPA may help some people. Whether it really showed that or not is another matter, but the issue here is external validity. You take the results of this trial, done in a very controlled setting by investigators who all knew that the trial was going on, and you take those results, and let's move those to the community now. Let's say, can we apply this to the community at large? The fact of the matter is when that happened, there were some nasty things, in particular, like if you look at the Katzen study in Cleveland, where they had all of the hospitals in Cleveland, they looked at their results. They were nowhere nearly as good as the study results out of the NINDS trial, because there was all kinds of issues regarding protocol violations, and maybe the fact is that it may not have, TPA may not be all that good in the first place, and in this community study, it was a disaster, and patients were getting harmed by its use rather than help. So external validity is certainly an issue. You have a study that looks at STDs, and people come to the emergency department and look at how many of them have, on screening, have STDs. And this study is done in an inner city hospital in Detroit. Well, you take that. Can you extrapolate that to your community hospital in Wisconsin? No, I don't think you can. So the issue here is external validity, taking the results, moving them over. And that's one of the reasons it's really important that you know who are the people studied and who are the participants in a study, because that will help you decide whether this is a universal truth. We washed out all of these wounds with saline or tap water. Saline was no better than tap water. Well, I think I can take that, extrapolate that to all of our wounds within the confines of that study. They didn't use have dog bites, those kinds of things, versus a study that is in a very narrow population, and then you take a narrow population and it doesn't really extrapolate to your community. So I think that's important to know. Who's included in the study? Okay. Here's a couple of other examples. Everybody knows that aspirin basically will help you prevent heart attacks. VA study showed that. But the fact of the matter is the VA study had very few women. And when you really look at it, women get much, much less benefit out of aspirin prophylaxis than does men. So even in a study like that, you don't take into consideration women versus men, that there may be differences, and there are. It turns out it becomes an issue. Another thing is to look at who's excluded. A lot of these studies where they're giving antibiotics, they exclude immunocompromised patients, diabetic patients, people who we see, and if you don't know that they've excluded diabetics and steroid-taking patients and elderly patients, et cetera, and you take this as a universal truth that you don't have to use antibiotics prophylactically in dog bites, well, the fact of the matter is if you're going to use them in another person, you may not, their universal truth may not apply. So you need to look at who's been excluded from studies. There is a trend, as an example, in studies where people are using drugs to treat something pretty serious like pulmonary edema, myocardial infarction, exacerbations of COPD, there's a tendency to pick the sickest patients. And why do they pick the sickest patients? Because they like to show that their drug makes a difference in these patients. And to show that your drug makes a difference, pick the sickest patients. You know, there's this thing that's come up in asthma all the time. Does magnesium make a difference? Well, magnesium's never been shown to make a difference in mild asthma. where in fact beta adrenergics work fine. Where they get into trouble, however, is when you have a severe asthmatic and you're throwing the book at them and you're giving lots of betas and you're giving lots of ipratropium and you're giving lots of this and lots of that. Will you see a marginal benefit by giving a third or fourth line drug? And in those cases, perhaps you will. So the sicker the patients, the more likely you're able to show that adding therapy X makes a difference. And asthma and magnesium is probably a reasonable example of that. So there's this bias to pick sick patients in studies where they're trying to show that are of serious conditions where they're trying to show that their drug makes a difference. There's a bias on the other side to pick patients who are not particularly sick to show that drugs are safe for prolonged use. And this is like in the studies of diabetes or hypertension, where they said, we're not going to get a really complicated hypertensive patient. We're going to give them this drug, which lowers their blood pressure, and shows that everybody's fine, it doesn't cause side effects, et cetera, because we've got a population that, in fact, does not have a lot of comorbidities associated with it. And their goal is to show it's a safe drug. And it's easy to show that drugs lower blood pressure. So this issue about the acuity of the patient, in one case we're talking about what's called a high acuity bias, the MIs, the COPDs, the asthma, and in another condition you get a low acuity bias where you have the hypertensives or the diabetics whose sugars are 300 and we can show them making the sugar 200 and it doesn't hurt anybody. Whether it helps anybody is another matter. Spectrum bias, this is a great concept. So the question is, does a CAT scan rule out subarachnoid hemorrhage? Pretty straightforward question. But the answer is you can't answer that question unless you say how sick are the patients. If the patient is decordicant, disorbate, those kinds of things, unconscious vomiting, the CAT scan is extraordinarily good in picking up subarachnoid hemorrhages. If you have a person who has a little tiny warning leak, has got the worst headache they've ever had, but is conscious, talking to you, is got no neurologic findings except a headache, CAT scan is not so good in that subset. It might miss 5%, 6% in that subset. So the fact of the matter is that the severity of illness in this case determines the answer to the question. The same thing applies to how good is the CBC in appendicitis. Well, in rip-roaring appendicitis, we get a rigid abdomen kind of thing, and it's been like that for 4 or 5 days now. The CBC is probably absolutely terrific in corroborating the diagnosis of appendicitis. If you have a case of appendicitis, it started like 3 or 4 or 5, 6 hours ago, mild tenderness, no surgical findings, and it's still appendicitis, the CBC might be absolutely valueless in that case. So there we're talking about the spectrum of disease. The test will be related, the value of the test is related to the spectrum of disease, and I think you could pretty much understand that. You know, BNP. One of the things that comes up in emergency medicine all the time is how good is BNP in the gray zone cases. We don't need it for the obvious cases where it's not pulmonary edema, and we don't need it in the cases where it obviously is pulmonary edema. We need it in the gray zone cases. So the question is, how good is it in the gray zone cases? In the gray zone cases, it's not nearly as good as at the two extremes. Again, the severity of the illness or lack of severity of illness relates to how reliable this test is in helping you make the diagnosis. Another thing that comes up is what's called the Hawthorne Effect. This is where everybody knows the study's going on. So when everybody knows the study's going on, everybody's really careful about how they treat the patients, the measurements they do, following the protocols. Even if it's a randomized placebo-controlled trial, everybody knows the trial's going on. That basically biases the studies in terms of getting answers that you're likely to want. As an example, in the Hawthorne Effect, I have it here, Hawthorne Works. That was located in Cicero, Illinois. It was a division of the Western Electric, and what they did is they made light bulbs there. And these studies were done between 1924 and 1927, in case you want any cocktail conversation about this. And what they did is they changed the lighting in the factory and saw whether the change in the lighting in the factory affected production. And every time they changed the lighting in the factory, the production changed. Whether they made the lighting brighter or darker, it didn't matter. They changed it, everybody, hey, they changed the lighting, and they somehow knew that this was related to, we're studying productivity, and the productivity improved no matter what they did to the lighting. But after a period of time, went back to baseline. So that is called the Hawthorne Effect. It's something to be kind of aware of. Because, and probably the best example of this is NINDS, where they got, 12% got benefit, 6% got worse with thrombolytics in this controlled setting. But the fact of the matter is when it was extrapolated and brought to the community, there were some disasters. One of the things I think is really cool is the difference between disease-oriented outcomes and patient-oriented outcomes. Now this, it applies to emergency medicine, but it particularly applies to primary care. It's really easy to measure cholesterol levels. It's really easy to measure blood pressure, and it's really easy to measure blood sugar. And so if you have high cholesterol, diabetes, or hypertension, and we show you there's a drug that can change your blood pressure, your cholesterol level, or your sugar, that's easy to do. We can do a study, take 100 people, give them the pill, watch the changes, and they say, hey, this pill is cool, it lowers blood sugar. This pill is cool, it lowers cholesterol. This pill is cool, it lowers blood pressure. But the question is, does lowering your blood pressure, lowering your cholesterol, or lowering your sugar have any effect on the outcome in these cases, in the outcome of these cases? Lowering blood pressure, sugar, and cholesterol are good examples of surrogate markers. Surrogate markers. We don't really care about lowering your sugar or cholesterol. We want to know, do you have less heart attacks, less strokes, less kidney failure? And the fact of the matter is that particularly in the setting of blood sugar, we're not able to show that outcomes change when you change your blood pressure. I know that that sounds like heresy. And Wilford, what's that guy on TV? The guy who's talking about checking your blood sugar and you'll get your supplies for Medicare, et cetera. Wilford Brimley, yeah, that guy. There's no evidence that checking your blood sugar has anything to do with whether you're going to get heart attacks, strokes, or the like. I know that that sounds like heresy, but honest to goodness, trust me, that's true. So this is about measuring surrogate markers. The same thing is in cholesterol. You're going to take this pill, it's going to lower your cholesterol. Is that going to prevent your heart attacks? For the vast majority of people, the answer is absolutely no. I'm getting a little sidetracked here, but the fact is you can't look at surrogate markers unless you say, are these surrogate markers causally related to outcomes? And in these three common conditions, that answer is not the case. Let me give you an example, even in blood pressure. Yeah, there's a lot of different pills that will lower your blood pressure. Will all of these pills, to the extent they lower your blood pressure the same, decrease your likelihood of having a heart attack or stroke? And the answer is no, no. Some pills are more effective. Even though they get to, all the pills get to the same number, some pills are going to be more effective in preventing heart attacks and stroke than others, that, despite the fact that you got to the same number. This is a no-brainer coming up. This is the difference between relative risk and absolute risk, or a reduction. So you get a pill, and it takes you from, as an example, it decreases a negative outcome from 4% to 3%. So 4% of the people, when they were taking this pill, when they weren't taking this pill, had a negative outcome. And now, when they take this pill, 3% have a negative outcome. That's a 4% to 3% change. That's a 25% change. And every study that looked at this has basically said doctors respond very positively when people talk about relative differences, relative difference. So, geez, a 25% decrease, 25% decrease, that's pretty good. I'm going to get that pill. It might cost more, may have more side effects, but I'm going to get that pill because our patients are going to get a 25% benefit. But the absolute benefit was one person got benefit. Out of 4 getting no benefit, now you take the pill, 3 get a benefit. There was an absolute change of 1 person. 1 person out of 100 got a benefit. That means 100 people have to be given the pill to have 1 person get benefit. 1 person to get benefit. That brings up another concept called number needed to treat. The number needed to treat in this case was 100 people. 100 people had to be treated with this pill to get benefit to 1 person, which is really a strange concept in emergency medicine in particular, because we believe that every pill that we give out will help that person. You got pain? I got a pain pill for you. You have an infection, you got cellulitis, you got a bladder infection, I got a pill that will take care of your problem. In primary care, honestly, it's just the opposite. The vast majority of pills that are given out in primary care don't help the patient that they're being given to. And look at all these people who are on cholesterol pills. Lipitor costs $3 a day. It's $1,000 a year to take Lipitor, and you're going to be taking it for 10 years, 20 years. So it's a $10,000 or $20,000 a year sale when one person gets put on Lipitor. That's why people want to talk to primary care doctors and influence their practice, because one prescription is a $10,000 sale or a $5,000 sale. One prescription of Keflex for us, nobody's interested in our Keflex prescription. Nobody's interested in talking to us because we're not prescribing anything that costs any money. Primary care doctors are giving out blood pressure pills, they're giving out cholesterol pills, and they're giving out sugar pills. And I mean pills to treat diabetes, not sugar pills. And yet, there's a lot that could be known about how many people get benefit out of taking a pill that will lower your cholesterol. Well, in terms of lowering your cholesterol, the question is, will it prevent your heart attack? How many people need to be taking a pill to do that? Well, there's an interesting article. This is entitled, "Do Cholesterol Drugs Do Any Good?" Do any good? Most of you may not have seen this journal article because it wasn't in a journal. It was in Business Week. Business Week. Here in Business Week, they're talking to people about, hey, you know, there's a thing called number needed to treat. And they get specifically into some of these numbers. Let me read you out of the Business Week article a couple of quotes. Lipitor and other cholesterol-lowering statins, when used in patients without heart disease, but who have risks for heart disease like high blood pressure. So we're taking somebody, no known heart disease, but they have some risk, high blood pressure being one. What is the number needed to treat to prevent one heart attack or one stroke? To prevent one heart attack or one stroke, between 70 and 250 people have to take Lipitor for 5 years, even if they have high blood pressure, to prevent one heart attack. Between 70 and 250 people is what's quoted in the paper to prevent one heart attack or one stroke. You have to take it for 5 years. Let's say, for the sake of discussion, that you have to take 200 people have to take Lipitor for 5 years to prevent one heart attack or one stroke. 200 people at $1,000 a year times 5 years is $1 million. Is society willing to spend $1 million to prevent one heart attack or one stroke? The mortality from a heart attack is about 6%. Are we willing to spend $1 million to prevent one heart attack or one stroke? And the answer obviously is no. But everybody who's taking their cholesterol pill thinks, hey, I'm taking this cholesterol pill because it's going to prevent my heart attack. It's not going to prevent their heart attack. They can take this for the rest of their life, and statistically, they're not going to get any benefit. If you told a person, listen, you're going to have to pay $1,000 a year, but the fact is only 1 out of 200 of you are going to get any benefit. We just don't know which one of it is. Are you going to be willing to do that? The society would say, hey, no way, man. Let me give you another number. Cholesterol and other Lipitor and other cholesterol-lowering statins, when used in patients without heart disease, but who have risk factors such as high blood pressure, the same group we were talking about before. How many people need to take this stuff for 5 years to prevent death or serious medical conditions? Death or serious, well, death is a pretty serious medical condition. Number is 500 people. Now we're talking about $2.5 million. $2.5 million to prevent death or one serious medical condition. Well, obviously I'm worth $2.5 million, but I'm not so sure about you. And they give other examples. Here's a great one. Zetia, which lowers cholesterol. That pill came out, everybody's going to take this stuff. How many people need to take Zetia to prevent to prevent heart disease? The number is, we have no idea. It's over 1,000. It's over 1,000. Why? Because the company admits that it has not been shown to reduce heart disease or heart attacks. It lowers your cholesterol, but it has not been shown to, that's your surrogate marker, but it's not been shown to improve your patient-oriented outcome, heart disease or heart attacks. What about Avandia? That lowers your blood sugar. Avandia lowers your blood sugar. Give it to those diabetic people. Number needed to treat to prevent heart attacks and other effects of diabetes in excess of 1,000 people, because they don't know, it's so high. The drug reduces blood sugar, but that does not translate into fewer problems such as kidney failure, renal nerve damage, or amputations. Wow, 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 wow. This is kind of like a light bulb here. Really, really important concept. Not necessarily related to emergency medicine, but certainly to medicine at large. All right, so let's pick up where we left off. We did number needed to treat. I'm going to give you some examples of numbers needed to treat. We talked about cholesterol drugs, and we talked about certain anti-diabetic drugs. What about, like, as an example, number needed to treat with flu vaccine to prevent one case of the flu? You got your flu shot, you think it's going to prevent you from getting flu? No. 23 people have to get the flu shot to prevent one case of the flu. Number needed to treat is 23. What about antibiotics for dog bites? Prophylactic antibiotics for dog bites. Number needed to treat is 16. 16 people need to be treated to prevent dog bite related problems. Now, what do you use to treat dog bites? Usually something like Augmentin, which is among the most known for its ability to cause diarrhea. As a matter of fact, if you look at, as an example, number needed to treat to improve otitis media. What they mean, everybody recovers from otitis media no matter what you do. So the idea here is, will you accelerate the resolution of otitis media? The number needed to treat an otitis media to decrease pain between days 2 and day 7 is in the neighborhood of 10 to 15 patients. 10 to 15 patients. How many people will get diarrhea on Augmentin? Number needed to harm, something like 8 to 10. So statistically speaking, kids are going to get diarrhea more often than they are getting resolution, accelerated, decreased pain between days 2 and 7 when you give them Augmentin for the treatment of otitis media. Why Augmentin, as was recommended by the American Academy of Pediatrics and AAFP for the treatment of otitis media, is beyond me, honestly. There's nice papers that show, and the other thing is now they're talking about high dose amoxicillin, 90 milligrams per kilogram per day. No, there's not really any good data to support that. We found a paper that said 40 is just fine. But in any case, you get into this issue of number needed to treat and number needed to harm. And in the case of antibiotics, the harm tends to be, you know, you get vaginal venereal infections and you get diarrhea and those kinds of things. Number needed to treat, I think, okay, we did that. How about compression stockings to prevent a post-op DVT? 9, that's pretty good. Ankle auto rules. How many people, if you use the ankle auto rules, will be spared an X-ray? You have to do the ankle rules on 5 people, and 1 of them will be spared an X-ray. So it only decreases X-rays by about 20%, which is a recurring kind of number. It is not a huge savings, frankly. And here's something else to consider. So you got this number needed to treat. I say, as an example, the dog bite. 16 people need to be treated prophylactically with antibiotics to prevent 1 dog bite infection. But what if, in fact, that infection, when identified, could easily be treated by starting antibiotics then? Would that not be a reasonable strategy to say, okay, I'll see you back in a couple of days, or when the thing starts to get more painful, red or something like that, come back, we'll treat it? The answer is, yeah, you could probably treat it then. So the question is, by giving prophylactic antibiotics, and we get a number needed to treat at 16, is there some alternative therapy that doesn't mean 16 people get antibiotics and one person gets benefit? And why don't we just treat the person when they develop an early infection? And you get into this issue of cost. 16 people had to be treated. Side effects, all the 16 people are exposed to the side effects, and only one's going to get benefit. So it's something to consider. And lastly, I want to talk about what's called composite endpoints. Composite endpoints. When a drug company wants to show that its drug is effective, what they'll do is they'll make a target that's really easy to hit. And this is particularly seen in cardiovascular studies where they're looking at, does this treatment decrease the risk of the need for PCI or revascularization, or does it decrease the risk of recurrent myocardial infarctions or stroke or death, those kinds of things. And you put those all together and say, if our drug that prevents any one of these 5 complications, we'll consider that it met its target. But the fact of the matter is that not all of those targets are equally serious. Death, that's at the top of the list. But what about things like a recurrent infarction? Well, you know, what's the mortality associated with a recurrent infarction? Probably pretty small. So when you make a big target, first of all, number 1, it makes it easy to show the drug was successful. Number 2, that target needs to be disassembled to say, hey, this is not equivalent to that. I'd rather not die, but this other thing that you put in the target is really not that big a deal. And the fact of the matter is, too, that when you actually look at the specific results of its trial, you might find the effect on death was nominal, or non-existent. And it really affected primarily one of these more minor elements of the target, which is clinically less significant, but it accounted for the vast majority of the successes of that drug. So you have to really be careful about composite endpoints, looking at what they consist of. Are they all equally horrible outcomes kind of thing, or not? Let's see. Yeah, okay, I think that for now, this year we'll cover the points that we wanted to talk about. Next year we're going to do another half hour going through some other things that you can be aware of in terms of analyzing studies and trying to get the best out of them for you and your patients. One of the things I would like to point out to you is this is a nice little paper called What is Critical Appraisal? This paper is, where did this come from? This is really strange because it was sponsored by a drug company. But in any case, the website www.evidence-based, not underlined, evidence-based-medicine.co.uk. It's only about 7 pages. Doesn't get into a lot of the super technical stuff at all. Very easy reading, and it's one of those things where I think if you spent just a little time with it, it will make a big difference in how you look at papers. Again, www.evidence-based-medicine.co.uk. It's from the Brits. Thanks very much for listening. We hope that you'll consider attending the 2009 courses of the EMA course. We've got dates and locations are going to be out on our website, EMA. What is our website? ccme.org. Go back down to the 2009 Emergency Medical Abstracts course. Thanks a lot.